Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I've been a cardiologist in Houston for more than 40 years. The feature presentation is ACC AHA 2020 Guidelines for Managing Patients with Mitral Stenosis. Diagnosis, severity, and what are the recommendations. So we're going to get a comprehensive review of mitral stenosis from a clinician's point of view as how we at bedside, in the office or at the hospital, make a decision as how significant is the mitral stenosis, how is it affecting the patient's overall condition, and how do we approach this patient, what tests do we do, and how do we determine what this patient needs. So this is based on the 2020 ACC AHA guidelines published in circulation. You can get a free copy of this by just Googling the title, and I would recommend strongly to download the PDF copy and read through the entire process. It covers all the different valves like the aortic stenosis, aortic regurgitation, tricuspid regurgitation, mitral regurgitation. I have already prepared a presentation on mitral regurgitation. You can watch that one. There's a separate presentation on aortic stenosis, which is a very comprehensive coverage of aortic stenosis guidelines. And this presentation is on mitral stenosis. As you know, the mitral valve separates the left atrium and the left ventricle. And when we look at from the left atrial side, this is how it looks. We have the anterior and the posterior leaflets along with chordae that attach to the papillary muscles. This is the normal configuration of the mitral valve opening, and in patients with the mitral stenosis, there is adherence of these leaflet flaps along with shortening of the chordae tendineae, calcification, restricted mobility, leading to narrowed opening of the mitral orifice. And we may see along with that some evidence of calcification in the different regions. How prevalent is mitral stenosis? Mitral stenosis is very prevalent in the eastern part of the world, especially like India, China, and other eastern countries. In India, the incidence of rheumatic heart disease and mitral stenosis is of a tune of 100 to 100, you can follow my green arrow here, 100 to 150 cases per 100,000 population. Taking into account that India has 1.3 billion people, you can estimate there must be 1.3 million people with some degree of mitral stenosis and rheumatic heart disease. Whereas in Africa, it is 35 per 100,000, whereas in the United States, the incidence of mitral stenosis is 1 per 100,000, and translate that into 330,000 population, it comes to approximately like 3,300 cases, or it may be even less, unless we see some other people who have immigrated from the East who may be having some evidence of mitral stenosis at a later stages in their lives. Talking about stages, 2/3 of this are seen in female, and most of them become symptomatic at the age between 30 and 40 years. It is very important to understand the population who is involved and what is the age group and what are the symptoms they present with and how do we diagnose. As you know, mitral stenosis creates a gradient between the left atrium and the left ventricle. Because of the narrowing, there is increased pressure in the left atrium, leading to reduced stroke volume going into the left ventricle. Because of this adherence, calcification, fibrosis, nodules, and narrowing of the aortic valve, we get a gradient which is recorded by monitoring the blood pressure, monitoring the pressure, hemodynamic pressure in the left atrium, or using a capillary wedge pressure as a surrogate of left atrial pressure and comparing that with the left ventricular end diastolic pressure, and we see this gradient here. In the 80s and 90s, when I was doing heart catheterization, we had to put a Swan-Ganz catheter and put a catheter in the left ventricle and simultaneously record these pressures and get a measure these 10 different sections of this diastolic phase and come up with a mean mitral valve gradient. And it was much more complicated if the patient had atrial fibrillation. But today things have changed. In year 2020 beyond, we have echocardiography, which is the gold standard for diagnosing my degree of mitral stenosis and all associated problems related to mitral stenosis, so that it has simplified our approach to dealing with patients with mitral stenosis. But nonetheless, you may get a diagram like this in your cardiology board exams or medicine and asked to interpret what you're seeing. That's why I put this one in, because the hallmark of diagnosis of mitral stenosis is based on two-dimensional echocardiography. And a ton of information can be obtained from two-dimensional echocardiography, and all of those points are going to be utilized in deciding what is the diagnosis, how severe is the mitral stenosis, what are its implications on the overall cardiovascular system, what are its implications on the patient as a whole, and how do we approach these patients based upon the degree of mitral stenosis. So let us look at each one of these items, because the reason I'm emphasizing these points before we go into the classification of degrees of mitral stenosis and the plan for that, we need to know what we are talking about. And that's what we are talking about. We are talking about criteria that are used by the ACC and AHA to determine how significant the stenosis is and what are the associated complications and what do we do with that information to see how best we can help these patients with mitral stenosis. Talking about the findings, echocardiography, we can look at the leaflet thickening, we can look at calcification in the leaflets, we look for the mobility of these leaflets. As you can see, a doming effect because of the adherence of these leaflets together and shortening of the chordae tendineae, along with annular calcification. Sometimes these valves can get infected and you can see tiny vegetations. There may also be some nodules built up because of chronic inflammation. Then we see this doming effect, which I talked about. And of course, when you do the planimeter, either using a short axis of 2D or a three-dimensional echo, we can get the mitral orifice. The shortest or the smallest mitral orifice we get should be the number that should be used. The reason I say that is because if you measure the mitral valve orifice here, it is going to be much larger compared to if you measure the mitral valve orifice here. So when we are doing a two-dimensional echocardiography or a three-dimensional echocardiography, we need to put the probe right at the point where the mitral valve opening is the least or minimum, and we need to planimeter that area to determine the mitral valve area. However, if this area is highly calcified and fibrotic, the blooming effects can distort the lumen and give you a falsely high or falsely reduced valve area. So there are a lot of technical issues which need to be taken into consideration. So these are some of the hemodynamic effects of the mitral stenosis. And of course, we have the pressure half time, which I'm going to elaborate in a minute. Along with that, we look at the left atrial dilatation, pulmonary hypertension, which is the complication of long-standing mitral stenosis, and of course atrial fibrillation, which can be a manifestation of a dilated left atrium. There are a lot of points that are deducted from this a thorough examination of the heart using a two-dimensional echocardiography. And of course, if they are going for any interventions, a three-dimensional echocardiography and also transesophageal echocardiography would be exceedingly important and vital to manage these patients. And in fact, if they are going for a balloon valvotomy, the transesophageal echo will be part of the procedure when it's done in the cardiac catheterization lab. Anyway, let's continue with this. Pressure half time is one of the important parameters that we measure in the 2D echocardiography pulse Doppler to determine how significant the gradient is across the mitral valve. And as here's the E, and then we have the A, and we look at the peak velocity that was reached. Then we find out how much time did it take. At this peak velocity of 2, the gradient is 16 millimeters of mercury. So how long did it take for the gradient to drop to 8 millimeters of mercury? That is half time. The pressure half time is measured from the beginning of the peak of the E wave to the point where we expect the pressure to be half of what it was, like 16 millimeters of mercury here. And this distance is now measured in milliseconds. So this is the pressure half time measured in milliseconds, and we use a constant 220. Then we take this 220 divided by the pressure half time. That gives the mitral valve area. It is a highly accurate number, but it again depends upon how good the tracing pulse Doppler is and at what level the pulse Doppler is obtained. The closer we are to the narrowest opening, the better are the numbers, and also it depends upon the left atrial output. If the left atrium is in atrial fibrillation and the atrium is not able to contract and squeeze strongly, then we may get a spurious number, just as in patients with aortic stenosis with low output, low gradient, and low readings. Okay, so this is an important formula to remember if you are a cardiology fellow, but for everybody else, we just remember they give you all the report in the chart and tell us how significant that mitral stenosis is. So getting back to the echocardiography, we measure the pressure half time, and we also look for, using color Doppler, mitral regurgitation, or even continuous wave Doppler, we can look for mitral regurgitation. This is an important factor because if we are dealing with pure mitral stenosis, that's one thing. But if you are dealing with mitral stenosis with moderate to severe mitral regurgitation, then the plan of action is going to be totally different than if you are dealing with pure mitral stenosis. That's why the color flow and of course continuous wave Dopplers will help us to identify any degree of mitral regurgitation. And here are some examples of course this is from a degenerative mitral stenosis, which is commonly seen in elderly population with heavy calcification of the mitral annulus, restricting the valve leaflet movements along with adhesions. And as we can see, we not only have mitral stenosis, but also significant mitral regurgitation. And here, the pressure half time is considerably low, so the gradient is 4. And as the slope becomes more flat, then the gradient goes up. And if the slope is real slow, then the gradient could be pretty high. So we also have MAC, which is mitral annular calcification. Of course, I want to emphasize this is the echo of a patient with a degenerative mitral stenosis, which I'm going to talk to you towards the end of this presentation. So you want to stay till the end of the presentation. I get back to this chart again to show how the left atrial and left ventricular end diastolic gradient sort of matches the mitral valve movement, mitral leaflet movements on M-mode echocardiography. But today, I think the focus is going to be on using echocardiography to determine the degree of mitral stenosis. While we are talking about the degree of mitral stenosis, here we can say it can be divided into mild mitral stenosis, moderate mitral stenosis, or severe mitral stenosis. All these points I'm talking about lead us to decide how we sort of strategize these patients into various groups and then decide what treatment they need to go into. So let's pay attention to the points that we are making here. Pressure half time will tell us whether we are dealing with a mild, moderate, or severe mitral stenosis. Mild is greater than 1.5 centimeters square. Moderate is 1 to 1.5 centimeters square mitral valve area, and severe is less than 1 centimeter square. So that is based on the pressure half time, and based on the gradients. In case of mild mitral stenosis, the pressure gradient is less than 5, and in severe it is greater than 10, and in the mid we have in between. Then pulmonary artery pressure, which is an important point. I mentioned in the beginning, pulmonary hypertension is not good for patients with mitral stenosis when we are trying to plan an action. If the person has significant pulmonary hypertension and you try to fix the mitral stenosis, the patients may not feel better symptomatically because they have fixed changes in the pulmonary vascular bed. And that's why pulmonary artery pressure is an important number that we need to obtain when we do 2D echocardiography. If the pulmonary artery pressure is less than 30, then that's good. If it is between 30 to 50, it's moderate stenosis. But if it's greater than 50, that means we are already beginning to see some fixed changes in the pulmonary vascular bed, which is not going to improve with opening up the mitral valve. So this has to be carefully recorded because it has a prognostic significance of whatever intervention we do in patients with mitral stenosis of varying degrees. And I just mentioned to you about low gradient mitral stenosis, which can happen in patients with atrial fibrillation or grossly dilated left atrium. It's a totally different scenario, but it's important to keep in mind. When you do an echocardiography and you see the left atrial size is like 6 centimeters or sometimes bigger than the left ventricle, and the patient is in atrial fibrillation, the gradient may not be great, but the valve stenosis, the anatomic valve stenosis, could be quite significant. That's when we have to determine how are we going to help these patients. In these patients, we may have to do like an exercise test to see if we can improve their forward flow and if the valve stenosis gets worse. The other important factor that we look at when deciding what is the appropriate pathway we need to follow is known as the Wilkins score. Again, based on echocardiography, it is dependent on these 4 major categories, namely the leaflet mobility, subvalvular thickening. So we have the leaflet mobility, subvalvular thickening. It could be the leaflet thickening or calcification, valvular thickening, and the leaflet thickening itself. So we talk about leaflet thickness, leaflet mobility, and leaflet doming, which also comes into play, and of course the calcification. In degenerative, the older elderly population mitral stenosis, calcification is a major issue. And in the younger population, it's mostly related to the leaflet thickening, leaflet adherence, leaflet decreased mobility. So those are the things. So it is graded 1, 2, 3, 4. Grade 1 is, like single area of increased echo brightness, which is generally seen on echocardiography here, some mitral annular calcification, whereas the leaflets are nearly normal thickness, 4 to 5 millimeters, which is normal, and they have good mobility. Whereas class 4, no or minimal forward movement of the leaflets in diastole. So the leaflets hardly move because they are so fixed, they cannot move unless, see, the mitral valve is supposed to open like this, whereas here they hardly move during the cardiac cycle. We also have extensive calcification. There is considerable thickening, 8 to 10 millimeters. It's almost twice the thickness of the normal leaflets. So these are some of the criteria that are going to be applied along with all the other parameters I've been talking all this time to decide what needs to be done. Okay, so the decision-making points. So let's summarize this. First of all, we look at the pressure half time. If the pressure half time tells us that we are dealing with moderate to severe mitral stenosis, then we need to decide what pathway do we follow. We also look at the left atrial clot. If the person has a large left atrial clot, just doing a balloon valvotomy may not solve all the problem, and there is also a potential for systemic embolization, and we need to take care of this issue with anticoagulation for a period before we do any intervention. As I previously mentioned, we need to look at the degree of mitral regurgitation. Is it mild, moderate, or severe? If they have moderate to severe mitral regurgitation, then doing balloon valvotomy could make the mitral regurgitation worse. Atrial fibrillation changes the whole spectrum of mitral stenosis patients in terms of their clinical presentation, their symptomatology, their outcome, and any results that we can get with the interventions. So if at all we can catch these patients with mitral stenosis in the early stages, before the left atrium becomes too large, before they develop atrial fibrillation, that's the time to intervene to prevent enlargement of the left atrium and prevent the development of atrial fibrillation. But if they have atrial fibrillation, of course, we need to control their rates before we can do any procedure. And annular calcification is something we can do a whole lot, but if we recognize this, it will help us in terms of prognostic, as a prognostic indicator as how well any interventions is going to make a change. Pulmonary artery pressure I already talked about. Now let's move on to some other issues that we need to, some of these things I already mentioned. The other important issue we need to consider is anticoagulation. Patients with mitral stenosis, if they have left atrial thrombus, they need to be on anticoagulation. Patients with mitral stenosis, if they develop new onset atrial fibrillation, they need to go on anticoagulation. Even if you do balloon valvular commissurotomy, still if they have pre-existing conditions like grossly dilated left atrium, atrial fibrillation, left atrial thrombus, they still need to be on long-term anticoagulation. And that is an important factor to take into consideration, especially if you're dealing with like the women population in the ages 30 to 40, the side effects of anticoagulation is an important factor to keep in mind. We talked about mild, moderate, and severe degree. Now we're going to talk about the stages of mitral stenosis. This is an important chart that is in the ACC AHA guidelines, and this is something we need to sort of get accustomed to, because the clinical pathways are based upon these classifications of mild, moderate, severe mitral stenosis plus the stages of mitral stenosis. So let's take a quick look at stage 1, at risk of mitral stenosis. Mild valve doming during diastole, normal flow velocity, no hemodynamic changes, none. So we can, stage A, we don't need to do anything about it. Stage 2 is sort of a mitral valve area is greater than 1.5, diastolic pressure half time is less than 150. So this is mild mitral stenosis. So stage B, we don't need to worry about it. So the only two things that we need to worry about are stage C and stage D. Of course, stage D is worse than stage C. So let's look at stage C. This is rheumatic valve disease, valve area less than 1.5, and the diastolic pressure half time greater than 150. But it is not critical, like it is not greater than 220 milliseconds. But still, there is severe left atrial enlargement and PA pressure is greater than 50. So this is getting close to a point where an intervention should have been done yesterday. So keep in mind, all these things are very important in making clinical decision. And of course, D4, I don't need to tell you, all the numbers are bad. The mitral valve area is less than 1.5, pressure half time is greater than 150 milliseconds, the PA pressure is elevated greater than 150, and decreased tolerance of exercise, decreased exercise tolerance, dyspnea with exertion or mild activities. So now this is like a functional classification plus hemodynamic classification, because we are talking about pressure half time and also pulmonary artery systolic pressure. So taking all these points in mind, now I think we can make a reasonable decision as what are we going to do with these patients based upon the degree of mitral stenosis, based upon the stage of the mitral stenosis, and what are the options available, and how do we proceed. Okay, now we are finally at this point. Rheumatic mitral stenosis, severe mitral stenosis, as characterized by mitral valve area less than 1.5 centimeters, or preferably less than 1 centimeter square. And remember, I talked about symptomatic stage D, the one who has a mitral valve area less than 1.5, pressure half time probably greater than 200 milliseconds, along with pulmonary hypertension, if the leaflets are pliable, and if there is no clot in the atrial appendage, and if the mitral regurg is less than 2 plus. Remember how many restrictions are there? Diagnosing is one thing, but dealing with these restrictions is another thing. That's why these flowcharts are so exceedingly important for us at bedside to decide how do we make a decision on what do we tell the patient, what do we tell the family. So if we are having stage D, which is for advanced stage, if they still have pliable valve, no clot, mild mitral regurgitation, they can go for percutaneous mitral balloon commissurotomy. And here's the description. I had to look it up. And they say this should be done only in comprehensive valve center. I absolutely agree with this, because the number of cases in the United States are like less than 3,500 cases based upon the statistics which I presented in the first slide. And I don't think every center should be attempting these because there are a lot of complications related to the balloon procedure itself, such as worsening of mitral regurgitation, embolic events, things like that. However, if the leaflets are not suitable and if the patient has more than 2 plus mitral regurgitation and is having New York Heart Association class 3 to 4 symptoms, now we are talking about severe heart failure. We were just talking about pulmonary hypertension until now. Now we are talking about class 4 heart failure. Then this patient may be a surgical candidate. Mitral valve surgery is a class 1 indication. If he is not a surgical candidate, then we could possibly try the balloon commissurotomy, which is a class 2B, which means plus minus results. But if it can help the patient, it's worth it, 50-50. Now let's talk about symptomatic stage C, which was one step less than stage D. The leaflet, same thing. If these are pliable, if the PA pressure is greater than 150, we do a balloon commissurotomy, and this is a 2A indication. Whereas if the person has a new onset atrial fibrillation, we can do, but that's a 2B indication, saying the results and benefits versus the risk, they are equal. On the other hand, if we have a progressive mitral stenosis, mitral valve area greater than 1.5, they only have exertional symptoms, the stress hemodynamically significant mitral stenosis, pliable and no clot mild mitral regurg. So remember, I told you about there are some patients who, because of atrial fibrillation, may have low forward output, may have low gradient, and sometimes it's difficult to determine whether they have a significant fixed mitral stenosis. And in these patients, if we do a stress test and if it shows significant mitral stenosis, then we can proceed with the procedure, the percutaneous mitral balloon commissurotomy. Let's remember that. Prosthetic valve requirements. So if these patients need surgery, let's say he was not a balloon angio commissurotomy patient, now needs a mitral valve prosthesis. The mitral valve prosthesis replacement is based primarily on the age. Less than 65, you consider a mechanical mitral valve prosthesis, which is a class 2-1 indication. If we are greater than 65, bioprosthetic mitral valve is preferred. We had to talk about anticoagulation. Anticoagulation is an important aspect, especially in patients if they have left atrial clot, if they develop atrial fibrillation, and they need to be on long-term vitamin K antagonists. And that's an important thing to keep in mind. Just remember that, and plus if they have a prosthetic valve, obviously if they have a mechanical valve, they need to be on long-term anticoagulation. If they have a bioprosthetic valve, then it may be on short-term anticoagulation. Let's talk a couple of words about calcified mitral stenosis, which is seen in elderly patients like in the late 70s or 80s who have very heavy calcification of the mitral annulus, the mitral leaflets, and even the chordae. There's heavy calcification. It's called the MAC. If you do a CT of the mitral annulus for calcium score, and here you can see 16,505 Agatston units. That's pretty high amount of calcium in the mitral annulus. When we are talking about calcified mitral annulus, it is a degenerative disease involving the mitral apparatus. It is seen in elderly patients. Leaflet mobilities may be okay. There's no leaflet fusion as we see in patients with rheumatic mitral valve disease, calcification. Their 5-year survival is less than 50%. They are high risk for any type of intervention. I think if they developed heart failure, we can treat their heart failure symptoms. If they are having atrial fibrillation with rapid ventricular response, we can try to control their rate and try to minimize their symptoms. But beyond that, any intervention has got to be like a last ditch effort because they are frail, they are elderly, their tissue plasm, their system is not strong enough to handle any surgical risk. So ladies and gentlemen, this is a very quick comprehensive review of what is mitral stenosis, how do we determine the degree of mitral stenosis, what are the various stages of mitral stenosis, and how do we diagnose these various degrees and stages, and what do we decide on based on these facts. I hope this has been educational to you. I have a whole series of ACC AHA guidelines on practically every topic, and here is the link to listen to one of those presentations. And if you want me to prepare an ACC AHA guideline on a topic that I have not already covered, I'll be more than happy to do the research and try to get all these basic elements that go into those flowcharts and try to understand those and then connect them to the flowcharts that are put out by the American College of Cardiology and the American Heart Association, so that when we look at the chart, it takes us into more practical approach in terms of how do we decide at bedside, depending upon the patient's symptomatology, echocardiography, EKG, X-ray, CAT scan, and all of these things. In that way, it is much better than looking at class A1 indication text, class 2A indication text box. I hope this has been educational to you, and please do subscribe to our YouTube channel. I will see you in the next presentation. Thank you so much.